Okay, very good. So maybe some playtime today, but we're definitely going to knock out the rest of the lecture. And yeah, chapter 30. All right, guys, a lot of today, or especially this chapter, is going to be review, especially of anatomy. We're going to go back over that briefly, but that should be some info from the human body chapter, right? So now we're going to talk about injuries that can occur to these different body regions and how we're going to treat them. All right, tell me about the contents of our abdomen. First off, how is it divided? So we have 4 quadrants. How do we label the 2 up here? Right upper and left upper. Remember, guys, right and left is always going to come first when labeling these quadrants. Who's in my right upper quadrant? Okay, gallbladder, liver. All right, who else kind of cohabitate? So remember, your pancreas kind of hangs out in between your right and your left upper quadrant. All right, who's in the left upper quadrant? Stomach. Who? Nope. Liver's right upper quadrant. Spleen. We need to keep that guy in mind, right? We'll come back to that, but remember that spleen's in that left upper quadrant. Right lower quadrant. So appendix. What else? Okay, so female, an ovary, intestines. All right, what kind of shared space for the right and the left lower? Bladder, right? Left lower. An ovary again, ideally, right? Intestine, okay, and then again that bladder kind of shares both of those lower quadrants.
So we're talking like this we exclude like kidney and other things.
So remember, guys, where are the kidneys at? The retroperitoneal space, right? They have their own kind of habit or home. So we don't really consider them part of the abdomen as so much that retroperitoneal space. But yeah, we'll get to those in particular. Okay, guys, where are your kidneys? Okay, so the flanks. Okay. All right, so here is the layout of the abdominal quadrant like we just talked about. Guys, we've got 2 different types of organs, right? What are those? Solid and hollow. All right, if I have a solid organ, what's my biggest concern when it comes to trauma? Bleeding, right? Internal bleeding especially, right? Especially who? Spleen. Guys, the spleen is very, very vascular. Why is it vascular? More so. Okay, so that's the what for the red blood cells? Elephant graveyard, right? And they reach the end of their lifespan, they get dissolved, reabsorbed, filtered out, right? And also there's, blood supply for a rainy day, sometimes up to half a liter. It just kind of hangs out there just in case the body needs a surplus. All right. What are we worried about with hollow organs?
Within the hollow organ leaking out.
So infection / exposure, because guys, remember that with hollow organs, they're containers. All right, they're supposed to be intact. They're supposed to be structurally sound because we don't want whatever contents are inside of that container out to the surrounding organs, surrounding tissue, and eventually bloodstream, right? So we're worried about maybe exposure to or potential infection, right? Any type of major acidity, especially with the stomach if it gets perforated. So yeah, everybody good with anatomy and then what we're concerned with for hollow versus solid organs? Okay. Imagine that. We have closed and open injuries when it comes to the abdomen. What do you think closed is? Skin's not perforated, the skin's not penetrated, skin is intact, and open. Skin is open. All right, the contents of the abdominal quadrant cavity are open to the outside world. With the pattern of most of the open versus closed, typically, guys, those closed injuries are going to be mostly secondary to what? Yes, blunt trauma, right? And typically when we see those open injuries, open area injuries, it's going to be secondary to penetrating trauma, just by definition, just by nature, okay? All right, so you guys can't really see this, but what does that look like to you? Okay, maybe a bruise. All right. Guys, what's important to remember when it comes to if we find any discoloration or contusions? What do we need to be thinking about? Okay, we need to take a step back and look at our what? Look at our MOI, right? Because this could be possibly one or two things, right? It could be an external, just a run-of-the-mill contusion, right? Those capillary beds got burst from typically blunt trauma, and it could be towards the surface. It could be a superficial injury. But sometimes, guys, when we see that discoloration, that presentation of the blues and the purples and the dark colors, what also could it represent? It could represent internal bleeding, right? If we've got a lacerated or a ruptured solid organ inside the abdominal quadrant or cavity, mix those up, and that blood is accumulating and it's starting to push up against the skin, that can also present with that discoloration. So just remember, take a step back. Is this a significant MOI, right? Do I need to possibly be concerned that I do have some internal bleeding, or is this a non-significant MOI and it's probably an external contusion? Because what's something else we can look at? We can take a step back and look at and say, oh, this may be more internal versus external. Color of what? Okay. Okay, so what would a yellow bruise represent? Yeah, an older. Okay, but like if it's an acute, if we can say, hey, I know this is a recent injury, we can also look at something else to give us maybe pretty strong indication that this could be internal versus external. Yeah, look at our vitals, right? Guys, the abdominal cavity can hold up to around a liter and a half of blood before we start seeing significant rigidity, distension, this discoloration, okay? So it is highly likely that if you're getting that discoloration of the skin secondary to an internal bleed, that we're probably going to be reflecting that in the vital, right? We could be pale, cool, clammy. We could have an elevated heart rate. If we're that far progressed, we could have decreased what? Blood pressure. All right, so take a step back, look at your patient's perfusion status. If we look like we're hypoperfusing, then we should probably say, hey, it's probably internal versus external, and then red flag's gonna go off, and we're gonna call trauma alert, we're gonna go code 1 to the hospital, right? Everyone clear on the definition of GERD, guarding rigidity and extension? Really hope by now we are. Okay. All right, so seatbelts, guys. We talked about this in trauma overview, right? That's part of what we're going to look at if we roll on scene to an MVC. Was my driver restrained? How do we know that our driver wasn't restrained?
Not in the seat where they started.
Okay, so maybe they're not in the seat currently. Maybe they got ejected or partially ejected. Huh? Potentially more damage. Okay, so they might not have those seatbelt marks. What else can I look at? What about the windshield? Okay, so cracks, yeah. So maybe that particular spider webbing presentation, right? But yeah, if your patient is not restrained, definitely going to have a higher injury level, right? We need to also make sure too, or be aware, because we can't really 100% say how exactly were you wearing your seatbelt during the time of the crash, but we need to understand that if they weren't wearing their seatbelt correctly, we could also see injuries from the seatbelt itself if it wasn't positioned correctly. So again, guys, the shoulder belt should cross over, start down here at the pelvis and go over and rest on the clavicle, right? Ideally crosses the sternum as well. And then the lap belt needs to go right over your pelvic bones. All right, if the lap belt is too high or too low, if the shoulder belt is non-existent, because a lot of people like to just put it behind them, right? You guys know anybody like that? Okay, or who was it? Their friend took the sensor out of their car. Yeah, all sorts of crazy stuff to just not be buckled up. So possibly if it is incorrectly positioned, if it's below, way below the pelvis, what can we worry about? Or what can we maybe see? Maybe some genital trauma. Maybe some pelvis injuries.
Bladder issues.
Bladder, a ruptured bladder, right? Who are we really concerned about this with? Significantly pregnant women, right? Trying to position around that baby belly. If they go above or on top of the belly, bad for baby, especially, but mom also. Okay. All right, guys, we talked about penetrating trauma. We talked about particularly maybe to the chest. We've already talked about that. How do we handle penetrating trauma to the abdomen? Okay, so stop any bleeding. What else? How else?
Are they exposed?
Okay, so let's just say, oh, I'm sorry, did I say penetrating?
Yes.
Okay, well, how do we manage an impaled object in the abdomen? Okay, so leave it, right? We don't yank the knife out or the iron rod, whatever's in the belly, right? We leave it, we secure it with a bulky dressing, and we transport those patients accordingly, right? We want to be more careful with them. We want to position them appropriately because we don't want to cause any what? Further damage by doing what? Moving that object, because we have no clue what different structures it's resting up against, right? But yeah, same concept. We're not going to remove it. We're going to secure it with bulky dressings to transport accordingly. So remember, guys, on that trauma overview, we talked about like the different velocities, right? Especially if it's a GSW. What are some things we want to see if we can get the information on? What was the caliber of the bullet? Okay, the distance. Was this point blank range or was this over several yards? What else? Okay, so maybe how many shots did you hear to maybe give us an indication for how many holes we might need to find? Guys, that's why we make these patients naked with a blanket, right? We don't need to get tunnel vision on just this one injury because there could be what? There could be more. There could be multiple. You don't want to be that crew that rolls into the trauma bay and be like, yeah, we got a single GSW, we got a penetrating wound here, we've got bleeding control, we're managing ABCs, yeah, we're rockstar team, woo, go us. And then they undress the patient in the trauma bay and they're like, oh, hey, did you not notice these 2 bullet holes down here on the leg? So guys, make sure we're not getting fixated on this one obvious injury. Make sure we're exposing, we're doing a thorough assessment, making sure we're not missing anything, okay? Fair enough. All right. Also, too, if it's a stabbing, if we can get the information, what do we want to know?
If it's rated or not.
All right. Was the knife or the blade serrated or was it straight? Maybe how long ago? Oh, how long the blade is. All right. How long has it happened? Yeah. So maybe the length of the blade to see where we are. You know, if it's like a 2-inch blade and it's at the hub of the abdomen versus an 8-inch blade, we're in a lot worse territory. All right. Cavitation, what happens here? This is for GSWs, we need to keep this in mind. Okay, so the pressure, the momentum of that bullet moving through, guys, it causes a big ripple effect. The vibration can cause a bigger diameter of injuries. It can affect the surrounding tissues and the surrounding organs. It's not necessarily just the bullets, the path of the bullet itself. That cavitation causes surrounding areas to be compromised as well. All right, so we already went over this, right? In the soft tissue trauma, what is this called? An evisceration. What's happened here?
It was internal, no longer internal.
Okay, so something is in that was internal is now external. Why? Okay. So what kind of trauma usually causes this? Penetrating, guys. Path of least resistance. We see a lot of intestinal eviscerations just because there is a significant link of intestines, like jam-packed really tightly. So the path of least resistance, if there is an external opening, those things are going to pop out like a little gag, a little snake in a can. Like you open it and like freeload and it like pops out at you. That's what the intestines are going to do. Are we fully exposing these patients? Yeah. This is a significant mechanism. There's no telling what else we have going on. Be careful to not cut what?
The organ.
The organ itself, right? So just carefully cut. Guys, you would be surprised in that adrenaline dump when you're cutting clothes off of a patient. Make sure you're cutting just clothes. All right, don't try your absolute best not to get any skin. Also, try not to get any what. We're not really going to have this going on for a trauma patient, but maybe for a medical patient. I had this happen on my truck one time. Maybe hair, yeah. Try not to cut hair. Huh? So any device, maybe, what'd you say? What about your 12 lead wires? Don't do that. Okay, yeah. May or may not have happened on my first. So just be mindful of that. Try your best to just get the clothes themselves. Guys, how do we manage this? Moist sterile dressing. How many sides do we secure it on? All 4 sides, right? And then what goes on top of that moist sterile dressing? Dry dressing. We also secured that dry dressing on all 4 sides. Guys, why do we use a moist sterile dressing first? So to preserve the integrity of those intestines, right? They're typically in a moist environment. We want to keep them moist so we don't lose any integrity of the tissue itself. Do we try to put things back to where they need to go? No. Let the surgeon, this highly skilled and trained surgeon, do that. Yeah, guys, this is definitely going to be considered a what if your patient is conscious. A distracting injury. Could you imagine focusing on anything else if your intestines or your stomach were just sitting there on display for you to see? No. All right. So again, another reason why we're fully exposing these patients, this is definitely going to be a distracting injury for the patient. It might not technically hurt a significant amount, but it is very visually shocking. All right. So make sure we're doing a head to toe. We're not missing anything on these patients. What do we not need to do? Or what do we need to be mindful of doing if we're doing a head to toe assessment?
Don't aggravate that.
Okay, so don't aggravate. We probably don't need to palpate for GERD, right? Probably not. What else do you need to keep in mind? Yeah, guys, don't roll them onto any organs. All right, I think I discussed this last on Thursday. I think I reported it on Zoom. But guys, a big crucial piece of managing and doing a safe assessment on these trauma patients. You are never going to roll onto what?
Injury.
An injury, right? So what if your patient has a right broken femur and a right broken clavicle? What side are you going to roll them on? On the left side. We do need to be mindful. We're still going to do a log roll, but again, guys, if we've got a broken femur, just be mindful of your hand placement so we're not trying to put a ton of pressure on those areas. All right. What if your patient has a broken right femur and a broken left clavicle? Scoop stretcher. All right, now guys, if they've got a broken right femur and just some minor like abrasions on that left side, that's okay, right? We're not going to cause any further damage or compromise our patient's life if we roll onto an abrasion, all right? But if it's a broken bone, if it's a significant, like an avulsion or partial amputation or anything like that, we're not going to roll onto that. Remember, if you have bilateral significant injuries, we're going to use a scoop stretcher to assess the back and then place them on a backboard. All right, what else do we never, ever, ever, ever roll? A compromised pelvis, a fractured or a dislocated pelvis. I don't care if that's the sole injury that they have, everything else from head to toe is totally fine. You never roll an unstable pelvis. All right, the beauty of this class is that I have recorded proof that I told you guys that, because that's a big issue with just all scopes of practice rolling an unstable pelvis. Never, ever, ever, ever do that. Critical fail. Okay, and you can kill your patient. Why? Okay, but why? Yeah, guys, if we've got any jagged pieces of bones because of a fracture or a dislocation, we've got significant arteries that go through the pelvic girdle that go down to the femoral arteries. So we could lacerate those arteries, bleed out. Are we gonna have a ton of external bleeding for this usually? Not usually, why? Okay, so the organ itself is a cork that is kind of blocking up or stopping up that hole, okay? Does that mean that we don't have any internal bleeding going on? No, all right, it's very possible that we have significant internal bleeding going on with this, but we're typically not gonna see blood loss externally because the organ itself is plugging up that hole. Yeah, guys, typically these hollow organ injuries, we're not going to see the side effects of the contents being released into the surrounding tissue or space immediately. Why? It takes a little time for that stuff to, whatever it is, the toxins, the acid, to kind of spread and start causing damage. Sometimes you can hear, or the patient can describe popping sensation. But yeah, it's just going to be that pain. Do you have anything to add to that personal experience?
It hurts.
It hurts.
A lot.
What does? You had several things hurt.
Just having air in your chest around your heart. It feels really weird.
Do you want to share your story with everyone?
I fell and hurt myself. I broke a rib. I had a little thorax. I had a little mediastinum.
Okay, so you broke a rib, you got a pneumothorax, and you had air in his chest cavity. How tall are you?
6'1".
He's 6'1". How far did you fall?
10 feet.
10 feet. That's not even double his body height. All right, so again, treat your patient, take a step back, look at your MOI, but technically per Grady standards, you wouldn't have even gotten a high triage code for that because it wasn't even more than double your body height. So what?
Hospital.
It wasn't. Shocking. Did you go to Grady?
No, it was an internal.
So yeah, just prime example. Treat your patient, not every, or your dispatch code, all that stuff. All right. Solid organ injuries. Again, guys, we are concerned about blood loss. We're concerned about losing too much content, so we could possibly go into hypovolemic shock because we're losing that blood. It's not in that closed circuit anymore. Liver is very vascular. It is the biggest organ in the entire abdomen, so it takes up a lot of real estate, pretty much all of the real estate in that right upper quadrant. Again, guys, we are, especially if it's a closed abdominal injury, what are we going to be doing? We're going to be palpating. We're going to be checking for that guarding rigidity extension, all right? Based on the areas of the abdomen, if we see any discoloration, that rigidity, that distension, that's why we need to know our anatomy to say, oh, hey, this is isolated to that right upper quadrant. We've got to have the livers involved in some capacity, right? So referred pain, again, most of this stuff, guys, remember the gallbladder has that referred pain that goes up to the right shoulder. Liver also has that referred pain that could possibly go up to the right shoulder. But again, take a step back, look at your MOI, and make sure that it's not just shoulder pain, that it could possibly be liver involvement. Spleen, guys, the spleen's pretty vulnerable. There's a lot of spleen lapse in trauma patients. A lot of times it comes from the steering wheel in NBCs, but the spleen is pretty vulnerable when it comes to sustaining injury from blood trauma.
That referred pain, like how would you describe it? Is it like a sharp or like dull, like kind of muscular pain?
I think it's kind of like a stabbing pain.
Oh, really?
I think it's kind of the same sensation, but you just feel it here and also there.
Okay, so it's not like a muscular, like, okay.
Typically not. Again, guys, very vascular, very prone to blood loss, guarding rigidity extension. Know your organ locations and make sure we're treating hypoperfusion if it exists. Guys, if your patient's in any type of any shock or showing any signs and symptoms of shock secondary to trauma, are they high priority or low priority? High. Okay, something's bleeding, and can we stop that if it's not external and in a place where we can do a tourniquet or wound packing? What do they need? An OR table. Okay. Question? Diaphragm. All right, what can happen here? You could not be able to breathe if we significantly injure the diaphragm. All right, what happens when the diaphragm becomes forcefully pushed upward? Could damage the thoracic cavity, possibly.
And like the stomach or abdominal contents, like,
Okay, so we could have a hernia of some type, the hiatal hernia, where stomach contents kind of come up into the thoracic cavity. What else? Possibly. But remember, if this happens, it's not usually a life-threatening injury. It hurts and it's scary for a second. You have the wind knocked out of you, right? It could be a smaller injury, a smaller or non-significant MOI, but this is if the diaphragm is forcefully pushed upward, all of that what's in your lungs gets temporarily displaced, that residual volume, okay? All right, so here are kidneys. They are solid or hollow? Solid. Again, guys, they are prone to blood loss. Typically, if our kidneys are significantly affected, what are we going to notice possibly? Blood in the urine. All right, sometimes, guys, this is hard to distinguish with trauma patients because they might not have gone or might not have urinated and after the trauma occurred, so they might not know that there's blood in the urine. What also can confuse this finding? Okay, so what other sources or what other areas? Yeah, so any type of soft tissue injury or genitalia trauma, because of the location of the urethra and the genitals, sometimes it can be confusing. Is this blood coming from, you know, the genital trauma, or are the kidneys also involved? All right, so what else can we do? Okay, all right. Inspect that flank area, that retroperitoneal space. Do we notice any discoloration, any contusions, anything that could suggest that this is kidney involvement and not just external genitalia? Okay. So guys, it says abdominal injury assessment is difficult. Why do you think this is true sometimes? There's lots of stuff in there, okay? Huh? We can't really see. We can have referred pain that can kind of trick us to say, oh, well, maybe they just like pulled a muscle in their shoulder or something, and maybe we don't have anything going on in the abdomen.
they can hold a lot of blood.
Guys, it can take a little bit for there to be obvious signs of internal bleeding, of internal blood loss, right? Depending on how large or small the laceration is to whatever organ or whatever vessel, it can take a little bit for that significant swelling, that distension, that rigidity to present. All right, subsequently, those signs of hypoperfusion, it can take a little bit to present. So this is just going to be something, guys, do a thorough assessment. If you're not seeing anything that's standing out at you, just take a step back, look at your MOI, and determine if what needs to be elevated or not. Your index of suspicion, right? So just make sure, hey, dude, your car looks like a freaking accordion, right? You might seem externally fine, but it's very highly likely or possible that we do have some internal injuries that haven't really presented themselves yet. So keep this in mind, especially if your patient's wanting to what?
Not go to the hospital.
Refuse. All right, guys, if there's a significant MOI and on scene, on site, at that moment, your patient's checking out fine, the vitals are stable, you're not noticing anything significantly wrong with the patient, that needs to be an AMA refusal. Because again, knowing what we know, these significant injuries can take some time to present. You could be fine now, but when we leave 30 minutes, an hour later, you know, you pass out, nobody's there to call 911, you could die. So make sure that that's an AMA. But strongly encourage these patients to go and get a head-toe workup, okay? Is anything about your scene size have changed? First and foremost, most important thing, your scene safety. All right. Guys, everything that we talked about in trauma overview that goes into looking at your overall MOI, raising or kind of lowering that index of suspicion, that's all going to go into your scene size up, right? Is everybody good on different aspects that we look for when it comes to those kind of things? Do we manage our ABCs any differently? Where are these patients going? Trauma center. The highest level trauma center, ideally. Again, guys, chief complaint, remember that we can have referred pain. Remember that we can have, what else? Distracting injuries. We can have, what else? That might not give us a true indication of chief complaint versus actual injury. Okay, so some altered mental status. Why might we have altered mental status? Okay, so maybe an underlying medical issue. Maybe the patient went to hypoglycemic state and then they crashed the car into the concrete median. All right, what else? Drug use, alcohol use, hypoxia. All right, so remember too, guys, when we test you in class and at registry for a trauma assessment, it's just gonna be trauma. All right, we're not gonna be mean and throw in hypoglycemia on top of a femur fracture and hematoma. All right, but in real life, you could have both. And it happens more often than you would think. All right, so what do I say about not missing anything? Every patient, every assessment, every question, every vital, every time. All right, just because it's a trauma patient, don't forget to check your 2 things that go commonly unchecked in trauma patients. Okay, your BGL and your pupils. All right, are your patient's pupils pinpoint? Okay, maybe we can give them some Narcan and we can change that altered mental status or change that respiratory rate. Okay, is their sugar 427 or is it 27? All right. Do we really use OPQRST all the time in trauma? Okay, maybe not every aspect of OPQRST, right? Why?
Or you know what the onset was.
Okay, so we know what the onset was. Well, maybe we could have somebody who like sprained their ankle like a week ago and now it's this big and they can't walk and now they're just calling, right? But why else do we not really all the time use OPQRST?
You usually see where it is too. You don't need to ask.
Trauma's pretty straight up, right? If your ankle is hurting, that's probably because you have an ankle injury. It's not the pain that we're going to experience with these trauma injuries is not sneaky like the medical pain can be. So typically we don't always use OPQRST when it comes to trauma. Have you ever had your femur sticking out of your leg before, or is this the first time? Guys, what do we manage first? Life threats first, and then we go to ABCs. And if we have time, we do what? That secondary assessment. Okay, because sometimes your patient gets shot up a block from Grady. The best you can do is put a tourniquet on and bag them all the way to the hospital, and that might be all the time that you have to provide that patient care to make sure you're taking care of life threats and ABCs. All right. If time allows it, guys, you're gonna have to learn how to get better time management skills. Okay, you're moving at a very rapid pace in the back of that truck on scene if you have a critical patient. All right, you're simultaneously doing a lot of things. You're going to be cutting off clothes. You're going to be doing a rapid scan head to toe. Do you notice anything? Hey, really quickly, you know, when you're on a break from bagging the patient, let's roll the patient. Let's check the posterior side. We're bandaging, we're packing up, we're still bagging. We're going to be multitasking, especially when it comes to critical patients. So just keep that in mind. What do we do when it comes to reassessment, especially with trauma? When it comes to interventions, how do we reassess that? Is the bleeding still stopped, right? If you put a tourniquet on, you know, right then and there, after that 30-second mark when it's applied, we should notice what? That the bleeding has stopped, right? That's how we know that we place it successfully. But what if we're putting, you know, like a pressure dressing on something else or like managing a soft tissue injury? we want to come back Q5 or Q15 and say, hey, I put those 4x4s on there to stop the bleeding. Is it still being controlled? Right? If we have to put a splint on, let's go back and reassess PMS to make sure we're not having any circulation issues. All right. What do we do if we have a soft tissue injury that's being managed by dressings? What happens when those dressings become soaked with blood? You put more on top and then secure those additional bandages. We don't ever remove the existing bandages because why? Okay, it could possibly be helping form a clot. If we pull it off, we start from ground zero. Okay. All right. Let me ask a question. Do you have a question? Guys, always take into consideration the integrity of our spine. So, guys, if it's a significant MOI, right? If we have blunt trauma or penetrating trauma here, who's to say that those that energy that's being transferred didn't go back and affect the vertebra? So, always make sure that we're assessing what to see if we have any indication of a spinal cord injury. Okay, so maybe step off, but what might give us the first clue that we need to really assess that spine?
PMS and lines.
Yeah, so check your PMS in all of your extremities, right? Pulse motor sensory. If you're checking for those distal pulses and you don't feel a distal pedal pulse or posterior tibial pulse, what are some things that can cause that to happen? What are we talking about right now? So it could be a spinal cord injury. Okay. Okay, and then also what else could cause that? Okay, so damage to an artery. What could cause damage to an artery? Damage to a bone. Right, so that first hint that we really should do, I mean, guys, you're going to do a thorough assessment every time, but really focus on possible spinal cord injuries if we have a deficit in that PMS status.
Will spinal injury present with loss of pulse at the extremity usually?
Possibly. It's possible that the compromise or the pressure surrounding that particular injury could cause subsequent pulse loss. Usually the pulse stays intact, it's just the motor sensory that's affected, but it's possible.
So if there's no indications of like spinal trauma, but the MLI suggests that it could be possible to still back all of them. Because if there's no PMS and it's not step off, they could still have.
It depends on who you ask. Typically, if we have a significant MOI and we have maybe some multi-system trauma, like we have injuries in different areas of the body, then yeah, we're probably going to back forward. But if we've got like a focused injury, even if the significant or the MOI was significant, if we do an assessment, we don't feel any step off, there's no pinpoint pain, PMS is intact, it's not indicated to back forward. Because guys, remember, we're moving away from backboarding, right? Why? It can cause more harm. Okay, so yeah, especially here at Grady, I don't want to speak for all other services, but here at Grady, there's very strict parameters that unless you have X, X, and X, you don't need to be backboarded. Do they backboard you?
For a microsecond. Also, it really hurts if you have an injury in your back and you're laying on a backboard, like a lot.
Yeah. So just if you have any suspicion, if it's altered mental status, distracting injury, or multi-system trauma, they need to be on the backboard. I mean, if we're thinking that our patient's going that route, we've got to have some really significant injuries or multi-system trauma. They should be on a backboard already, right? I'm not going to anticipate doing compressions on a patient who has a focused ankle injury. So, but yeah. All right. So we talked about some PMS deficits. What else might give us an indication that we definitely need to be backboarding this patient? Maybe pupil responses. So altered mental status. If we feel any step off, or if we have what? Because sometimes we could have what's considered like a hairline fracture of the vertebra, right? We might not feel that drastic or that dramatic step off. All right, what else can we say? Oh, this could be spinal. Let's just make sure that we do everything we can to prevent any further injury. Maybe bruising, pinpoint pain. What does that mean? Right, if I'm palpating somebody and I am palpating directly on their vertebra and they say, ow, that hurts. The second that I palpate right there on top of the vertebra, that's going to be pinpoint pain. If I go off to the right or to the left of the spine, I'm not directly touching vertebra. What am I touching? Muscles, soft tissue, right? So if they say, oh, it hurts when I go off to the left and I'm not directly on the spine, I'm probably not going to think that's spine related, right? It's probably a muscular injury. But if I'm directly on top of that spine and they say, ouch, when I palpate directly on top of the vertebra, that's pinpoint pain. We should probably go ahead and backward them, okay? Look at this dramatic reenactment. What's not good here? You don't need gloves on. You're just like, oh, you're Larry, let me grab your intestines. I got you, dude. Huh?
I'll hold that for you.
Everybody clear how we treat that? So here's a little better visual, right? If we have an evisceration, or if we have what? It doesn't have to be in the abdominal quadrant, it can be anywhere in the body. When are we going to use a moist gel dressing? When we have a significant underlying structure exposed. All right, so bones, organs, eyeball, brain matter. You could probably consider like the ligaments and the tendons significant. We want to preserve the integrity of that. So we'll put the moist dressing on. Guys, we're not going to secure typically like with tape all four sides because it's kind of hard to secure a moist dressing with tape, right? But we'll put the dry dressing on top of it and secure all four sides. Everybody good on that? All right, GI, again, guys, remember that the external genitalia is directly connected to the GI system. So we already kind of talked about, we could see blood and urine if the kidneys are significantly involved, but then we could see that kind of cross-contamination if we have any external genitalia injuries, particularly with a soft tissue, it could kind of cross-contaminate that urine, okay? What's going to be true across the board for genitalia injuries? Very distracting, very vascular, so we're going to have a lot more blood loss and very painful. There's a lot of sensory nerves. All right, so keep that in mind. How do we control soft tissue injuries for the male genitalia? Same as anywhere else in the body, right? If it's a laceration, if it's a degloving, if it's an avulsion. All right, guys, just because it's to the genitalia doesn't mean we manage that soft tissue any differently. Maybe have a little more sympathy. But yeah, just make sure you guys are managing the bleeding and treating soft tissue like you would anywhere else in the body. What's something we need to worry about? Dang it, that's the video I was going to put in here. The Office video where Andy rips his scrotum. You guys remember that? Where he's dancing and he does like the split and he rips the scrotum. I forgot to put that in there. What do we need to worry about with the male genitalia that we don't need to worry about with female? Everything's external, okay? So the male genitalia is going to be more predisposed or more vulnerable to that soft tissue injury. What do we need to worry about with these guys too? There's a different aspect, another aspect when it comes to possible trauma for male versus female. Okay, so we need to worry about the status of both the penis and the testicles, all right? Especially with the testicles, you can have the container, the scrotum, opened and ripped, all right? We need to worry about that because technically it would be an evisceration because it's outside of its cavity, if you will. All right, but we can also have something called testicular torsion. What is this? So some type of twisting or some type of pressure causes these ducts right here, okay, that go carry the swimmers from the testicles to out the urethra, they can get twisted and kind of like clamped down, okay? It's extremely painful. Is there anything that we can do to manage that? No. A sympathetic, ideally not as bumpy as possible, ride back to the hospital. How's this gonna present? Okay, very painful. Most of the times we won't see the actual like scrotum twisted. It usually happens internally and you can't really tell from external view. Possibly. Might not be a slow hanging fruit.
I feel like a lot of things you guys mentioned with testicular torsion and one other injury, one of them goes away when the patient lifts them and one of them doesn't. Do you remember that? It was during one of the lab days. I wrote down the testicular torsion, but I didn't write the other.
Might have been with another instructor, but yeah, I don't think I've talked about that. How else do you think it's going to present? Swelling, probably some bruising, okay, some discoloration. That brings up a good point too, guys. If you have any type of evisceration or testicular torsion or anything that is caused by significant tension, how do you think your patient's going to be most comfortable? With their legs drawn up to the abdomen, okay? So try to place them as best as possible in that position of comfort, just to make sure we're not putting any more tension on any vessels surrounding that injury. It's going to be less painful. But yeah, we don't cause any further stretching of anything that doesn't need to be stretched.
What causes that?
Loose underwear.
Huh?
Loose underwear.
Okay, loose underwear. You sound like you're speaking from personal experience. Okay.
They were very adamant about that when I started doing like outdoor stuff. Like, yes, they're all your boxers away.
Whitey tighties.
Yeah, they were like briefs or boxer briefs.
Okay. A lot of times too, from like contact sports, like if you get like maybe like a knee or a body part like to the groin, it can cause the twisting. Alright. Female genitalia, what are we mainly gonna see? External trauma, right? It's possible that if it is secondary to like a sexual assault or anything like that, we could see some internal damage. But how are we going to manage any kind of leak? Externally only. Do not place anything in your patient at any time, really, until you get to A or paramedic, and it's only medical equipment that you're starting, like an IV or placing a medical tube or an airway tube. Guys, you will control genital bleeding externally, okay? So get one of those trauma dressings, those trauma pads, and just kind of make like a makeshift diaper, if you will. But we're not going to insert any type of 4x4s or trauma pads into the vaginal opening to try to control bleeding. All right, guys, when do we even need to go about exposing and assessing and treating genital bleeding? As if it's a lot. All right, if I am concerned about going in the direction of hypovolemic shock, then I'm going to expose and assess and treat. If I can't visibly see any blood, like if it's not soaking through clothing, if it's not soaking up the mattress sheet, if I didn't just see a ton of it on scene, I'm going to leave it be. Right? If it's not potentially going to kill my patient or make my patient hemodynamically unstable, we're just going to let it ride, get to the hospital, and they can do all that stuff there. There's more witnesses there. They have better like malpractice, accountability type thing. All right. So we're only exposed and assessed genital regions if we're concerned, legitimately concerned with the amount of blood loss and how that will affect my patient's perfusion. Everyone clear on that? Okay. So kidney injuries. Again, guys, we're going to assess that flank area. They're not going to be any signs and symptoms of kidney involvement in the abdominal quadrant. Obviously, if we have a penetrating wound in that flank region, then we're going to be concerned. Also, too, guys, any type of lower rib involvement, because they are kind of semi-protected by the ribs down here. So it's possible that a fractured rib or a broken rib can penetrate the kidney. Bladder injuries are typically secondary to pelvic injuries. Again, those shards of bone are sharp. They can penetrate or lacerate the bladder. Who is this more common with? Geriatric patients, we do see a higher instance of pelvic trauma in geriatrics. But who else?
Pregnant.
Significantly pregnant women, especially in that third trimester. Why?
Bladder.
So the bladder doesn't really move, but it does what?
Moves down a little bit.
It's constantly under pressure. Guys, all of the organs in your abdominal quadrant get displaced and moved and squished when that third trimester comes around, right? That's why mom is always having to pee every 5 minutes, because the weight of baby and all those extra fluids are pushing down on her bladder. So when it comes to trauma, the bladder is much more susceptible to rupture because it's already under a significant amount of force. So smaller MOIs can cause bladder rupture in significantly pregnant females because of all the added weight and pressure. What might we see with this? How might it present?
You get bleeding through the urethra.
So maybe some blood in the urine.
Really low.
Huh?
Really low, like in kind of your pelvic region.
Okay, so yeah, it's going to be isolated right there to where that bladder is going to be.
Still void if rupture.
So what might we see an increase of?
Pain.
Possible incontinence, right? Because all of those contents are now just kind of free flowing. That muscular content might be painful to try to control. But yeah. Question over here?
No, I was just saying pain.
Yeah. So you need to be let in. So you read it here. Genital trauma is rarely life-threatening, even though your male patients will tell you differently. So just keep that in mind. Yeah. Guys, we'll go more so into the pregnant patient population when it comes to trauma injuries when we go over that chapter. Again, do not insert anything into the vagina. Please. Ever. While you're on the clock. I have to say these things, guys. I have to say them because.
No, what's your qualification on that?
I have to say them. All right, guys. None of this changes. Okay, guys. A lot of this stuff is just going to be across the board. If it's a soft tissue injury, we treat it like the soft tissue injury that it is. Can we do anything about a ruptured bladder? No. What might we suspect if we have a ruptured bladder? Maybe some pelvic involvement. Okay. We'll treat that accordingly, and we'll talk about that when we get to orthopedic. If it is an amputation of any part of the penile shaft, what do we need to do? Be really sympathetic and try to bring it with you for hopes of reattachment. That's a bad day.
Don't use it.
Don't use a tourniquet. If you had the ability to use a tourniquet, I would be very impressed. But yeah, don't use a tourniquet. It's not considered an extremity. Soft tissue cotton zipper. Okay. What do we need to keep in mind about this? Everybody seeing there's something about Mary?
The fact that they're flesh.
God, y'all are just killing me. All right. So what if we do have any type of soft tissue that gets caught up in a zipper?
Don't try to pull it out, first of all.
Okay, yeah, definitely don't do that. Should we try to unzip the zipper?
No.
No. No. What should we do? Okay, so use your shears and cut the pants around, like cut out that piece of the zipper that is attached to your patient. We're not going to try to unzip it. We're not going to try to tug on it, see if it'll pop out. We're going to cut the clothing to just leave it around the skin, but to prevent any further soft tissue damage by kind of like moving around or further pulling. Okay.
Never try to unzip it, but one of those bullets said it was a teeny mouth, but like totally ignore that.
Nope. Just cut the pants. I can, with almost 110% certainty, guarantee you that your patient would much rather have their pants ruined than have you do any of that before they get any pain medication. No. Just cut the zipper out. Don't try to undo it. Because yeah, you guys can't get pain meds too, so that's another big thing. We already talked about the straddle injuries. Particularly, we see these with who? Motorcycle accidents. All right, what happens here? So it's kind of like a wishbone effect, right? So we're worried about the integrity of the pelvis. What else are we worried about? Okay, so possibly femurs, yes, but particularly for the genitalia. Ripping of soft tissue. Okay, so a lot of times this is where we can see the scrotum actually be ripped or perforated. We can also see the perineum affected. What's that? You can use whatever street slang you want to, not when I'm being recorded, but what is this? Okay, there you go. It's the area of the tissue between where the scrotum meets the external part of the body and to the anus. So we see some soft tissue injury compromise there. How do we manage that? Like soft tissue injury, right? Position accordingly, appropriately. But yeah, if we've got that, we might have some other injuries going on depending on the MOI. Okay.
Would you ever have like a wound packing like situation somewhere like that?
Can we quickly go into indications for wound packing?
Where do we, okay, so wound packing is a substitute for what? Placing a tourniquet. Okay, where can we place tourniquets? Extremities only, right? So where can we pack wounds? In junctional areas. So axillary and groin. Guys, you're not gonna do any wound packing in the chest. You're not gonna do any wound packing in the abdomen. You're not gonna do any wound packing in the flank area. Only junctional areas are indicated for wound packing. Everybody got on that? Okay. We already talked about this. Such fun stuff to talk about today, huh? Yeah. Yes.
The other slide said to put during for hospital examination. So you just like, I don't know, put in a bag or something.
I mean, if you've got all the time in the world and be like, hey, can I just like scoop up or can you pee in this really quick? Sure. But they have their own ways of getting urine samples.
I have like a hypothetical, like,
Yeah.
may not put it directly out there.
Yeah. How could we collect urine anyway? Amos's bag. But yeah, that's not really our main concern. But if you got the time, you think about it, be like, hey, can you pee in this real quick? Thanks. Guys, for male and female genitalia, if there are any protruding objects or penetrating objects, how do we treat those?
Maybe anywhere else.
Secure. With bulky dressings, like we would anywhere else in the body, we do not remove them. Okay. That's all I'm going to say there. Rectal bleeding, again, for trauma-related purposes. Guys, again, I got on my soapbox when we talked about the gynecological chapter. Females are not the only sex that are vulnerable to sexual assault and rape. All right, please remember that. So it could be secondary to sexual assault if we have any rectal bleeding. It could be hemorrhoids. It could also be foreign body insertions. I'm sure everyone has seen the very impressive different surgical videos removing foreign bodies from the intestinal tract that started out in the rectum. Some of them are mind-blowing how that physically happens. But if it's there, leave it, transport accordingly. How do we want to try to transport these patients? Ideally on their side, right? If airway is not a concern, if this is the only isolated injury, we could possibly transport them prone. We don't want a said impaled or protruding object to be pushed any further. So just keep the position of transport in mind. All right. Yes.
If it is sticking out of their body still, do you do anything to make sure that like it doesn't go all the way into their body, or do you just hope?
Yeah, we're not really gonna like sit and pull traction the whole time.
High blood strength.
Yeah, no, like tie it to the stretcher handle. No, just position them appropriately. Oh, why did that? Okay. And just prevent anything from like bumping up against the object. Yeah, that's all we can do. Yep, I'm not gonna go any further comment on that slide. Do we need to go back over the approach in management of sexual assault patients? We want to try to preserve as much what is possible. Evidence. Remember, guys, we are there for what? Patient care. Okay, we're not there to collect what? Evidence or police report or anything like that. Make sure those lines don't get too blurred. But I think this was a quiz question. It was, you're there ultimately to do what for the patient when it comes to like sexual assault. It was like preserve modesty and have sympathy or something like that. And then, but the correct answer was provide patient care. Guys, being sympathetic and compassionate and effectively communicating with your patient should go into your patient care. Does that make sense? It shouldn't have to be like a sexual assault victim for you to have any compassion for a patient. So that's fully encompassing on providing patient care.
How's your follow-up differ if sexual assault was to a child as opposed to an adult?
Follow up.
Well, I'm just reading follow crime scene, right? So you come on scene and you have a child that was assaulted possibly.
Oh, what are we? Mandated reporter. Absolutely. You're getting PD involved. Okay. So we can try to encourage a patient not to change clothes. If the patient's clothes that the incident happened are right there next to you for whatever reason, PD is not on scene, you guys want to get transport started before PD gets there, we can bring those clothes with us. Discourage them from showering or doing any type of like physical cleaning of their body because that can take away evidence. Yeah. Questions, comments, concerns? Okay. Everybody good over here?